Good morning, good afternoon, and welcome everyone to today's broadcast, Cedars-Sinai Chaplain Conference Keynote, Chaplain-Nurse Collaboration, Exploring Evidence and Practice Implications with Dr. Elizabeth Johnston Taylor. I'm Andrew Andresco, Project Coordinator for Transforming Chaplaincy, and we are delighted you could all join us. Some housekeeping instructions off the top. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio or visual, please type those into the chat box located in the platform's dashboard. You will have the opportunity to submit text questions for our presenters by typing your questions into the questions pane of that same control panel. We will be holding two Q&A sessions, one following our keynote presentation and the second following our panelist session. You may send in your questions at any time during these presentations, and we will collect these and address as many as we can in the time allotted. And with that, I'd like to introduce Rabbi Dr. Jason Weiner, Director of Spiritual Care Department at Cedars-Sinai. Jason?
Thank you, Andy, and thank you for all your incredible help as we've prepared for this webinar. I want to, just on behalf of Cedars-Sinai, welcome everyone to this webinar that we're so excited about, and so glad you can join us as we move forward in the important work that we're doing in healthcare and chaplaincy and nursing, and it's such an honor to be able to do this with all of you. I want to do so first by also thanking Reverend Pamela Laser. She is the manager of the Clinical Pastoral Education program here at Cedars-Sinai. She's an incredible leader, visionary, and educator who has really done so much to make sure that this program would be a success and to initiate this program, as well as her team, Rabbi Sarah Baruch, who will be leading the Q&A session this morning, and Sunny Garcia, who did so much work on behalf of this webinar. It's also really quite an honor to be collaborating with Transforming Chaplaincy. They are the ones who provided us with the very inspiring initial transformative research literacy grants, which is what initially led to this actual Spiritual Care Research Conference, as well as George Fischette, who was our presenter actually at the first two conferences and is the one who recommended today's incredible guest speaker. That speaker is Dr. Elizabeth Johnston Taylor, PhD, RN, FAAN. Beth is a professor at Loma Linda University School of Nursing in Loma Linda, California. She has pursued a program of research exploring the intersection of spirituality, religiosity, health, and nursing for over 25 years. Inspired by her clinical experiences as an oncology nurse, which also led her to pursue a PhD at University of Pennsylvania, a postdoctoral fellowship at UCLA, and clinical pastoral education, as well as training in spiritual direction. Her life experiences include a 4-year stint as research director at the Mary Potter Hospice in Wellington, New Zealand. The desire to help nurses understand and support patients' spiritual health during health-related transitions has also motivated Beth to write extensively and lecture globally. Her books include Spiritual Care, Nursing Theory, Research and Practice, published by Prentice Hall in 2002. What Do I Say? Talking with Patients About Spirituality, published by Templeton Press in 2007. And Religion, A Clinical Guide for Nurses, published by Springer in 2012, as well as her latest book, Fast Facts About Religion, Implications for Nursing Care, just published by Springer in 2019. These provide clinicians with quick access to healthcare-related information about religions. She has received research funding from various federal, government, and private foundation sources. She comes highly acclaimed, and we're very excited now to welcome Dr. Elizabeth Johnston Taylor.
Thank you so much, Chaplain Jason. Well, I want to welcome you into my home here in Pasadena, California, where the heavens have been telling a lot during the last, about 6 hours. We have had a lot of lightning and thunder and gushes of rain, which in our very drought-ridden land is a generous gift. So just in case you hear some rumblings outside my window, that's what's going on. Okay, let's see if this person who is acclaimed to be so brilliant can actually bring up her slides. Okay. Andy?
Yes.
Oh, here we go. I got it now. Okay. Oops. Okay, thank you. All righty. So let me tell you about what brought me to where we're at. Many years ago, when I was first starting out my research career, I did a survey with some colleagues about how Oncology Nursing Society members perceived the spiritual care they gave and what their attitudes and beliefs about that were. And we had several open questions about what they did. And in that data, they talked sometimes about their collaboration with chaplains. And it was those findings I then wrote up into this article, and it's those findings that planted this seed many years ago. I was pleased to see that 84% made referrals to clergy, but there were 17% who said they rarely or never did it, and nearly 2 out of 5 who said that they just did it occasionally. That really surprised me, and I wondered why. And when I looked at the data, here were the most common answers to the question. They said, sometimes I don't like the chaplain. I perceive the chaplain as unfriendly or insensitive, or I just don't know the chaplain, so I don't know if they're safe. Or I've experienced them as never available. Or the chaplain seemed too busy to me. Once one refused to come, so I wrote them off. Or others talked about chaplains being inadequately trained, and ouch, one wrote that they thought chaplains were trying to be pseudo-psychiatrists. Others talked about how they experienced chaplains as interfering with nursing care. So I thought, yikes, this isn't good. And so over the years, I found myself having just collecting anecdotal evidence, talking to people at conferences or at the various settings, and asking them, nurses, but then also chaplains, asking them about the collaboration that occurs between the two fields. And I didn't always hear a positive story. So that led me eventually to say, I want to see whether or not this is just incidental, anecdotal, minimal, a rare occurrence, or is there something bigger going on? And so that led me to about 4 years ago doing a survey of chaplains who are members of the Association of Professional Chaplains. We actually rolled out an online survey, and literally within about 2 or 3 hours, the survey shut down because we had so many respondents. It might have been because we offered a $25 Amazon incentive, but it is also conjectured by chaplains involved with helping me with this, that perhaps it's because it's just, it pushed a button. It's a topic they really wanted to see light be given to. So I'm going to be sharing some of those findings with you, but also just to explore the topic in general. So my goal here is to not only just name what, I'll put it right out there. I would say there's some tension between these two fields. It's not just tension though, there's a lot of good going on, but just naming it so we can explore it and improve it. So in the process of doing that, wanting to answer questions like, why is it important to address? What factors might be contributing to it so that we can maybe address those? And in the process, I'd like to review the existent empirical evidence and what little literature has been written on the topic. And I'll just say right now, I've reviewed the literature back to the early 90s, and I would say altogether, including the empirical research studies, but also a few, shall we say, just clinical articles that have been written. I would say there isn't more than 30 or 40 articles out there in the literature that's specifically on this topic. I mean, of course, there's a lot of growing amount of literature about chaplaincy and its benefits and so forth, but this intersection between nurses and chaplains is still not receiving much attention. Okay, and then at the end, I'd like to just sit in my armchair and offer some suggestions that can be entertained perhaps as to how we can improve our relationship. So here we go. To begin with, though, I'd just like to kind of get a sense of who you are and what you think. We have a question here. Andy's going to bring up a poll, and you just simply punch in the button that is the best answer for you. So which of the following is the most important reason you think for us as nurses and chaplains to collaborate? Is it because there just aren't enough chaplains? Is it because nurses are generalists and need the expertise of chaplains? Is it because together shared perspectives and skills will enhance care? Or is it something else that you might want to write in the question box? And we'll just take 10, 15 seconds for this. All right. I'm glad to see a little diversity, but there isn't a lot. So we'll close the poll down. 3, 2, 1. Go ahead. So you're probably not surprised, but the most common response is indeed by sharing our perspectives and skills, we will enhance care. I think that's probably the answer I would have given as well, but I would say the others are bona fide answers as well. All right, so let's. Okay, so Andy, I'm not able to forward my slides now. Okay, yeah, maybe I'll just need to say next slide.
There you go. Yeah.
Okay. So if I was to synthesize all this literature, well, which isn't too voluminous, but to answer the question, why should nurses and chaplains collaborate? Here's what I have found offered in the literature. First of all, to me, the strongest evidence is that when there is a team approach to spiritual care, it is linked to things like patient satisfaction, quality of life, and even decreased healthcare costs. Now, granted, these are just very few studies, pretty small studies, but just so beginning evidence to suggest these things, which really aren't a surprise, but they're the kinds of rationale that would be helpful to take, I would say, to a supervisor and say, here's why you need a chaplain, and here's why we need to be working with your staff. There's also literature that documents how nurses do value chaplains and want to work with them, even though there is hesitation on some fronts, which we'll talk about further. Then there's just simply the reality. There's too many patients, too few chaplains. And the fact that nurses are the ones who are 24/7, at least in an acute care setting, but even in community settings, it's the nurse who's most likely to be physically and emotionally present to a patient, the most likely to have rapport. But even though they may have rapport, they may lack the skill and ability to be present to spiritual needs and to address those. So really need to collaborate with the chaplain. Next, please.
Well, you had done it on your own, Beth, so you were able to advance it on your own to get to this slide. So.
Oh, really?
Yep, they're all set.
Oh,
yep,
okay.
You got it.
Now it did work. Okay, so close this up. Yes, then what's interesting is over the last 30 years or so, the chaplain referral rates have been documented in a handful of studies, a lot of them back in the early 2000s done by folks there in New York at the Healthcare Chaplaincy Network. One of these being a study where they did a chart review of literally thousands, I think it was like 14,000 medical records in several hospitals in the New York City area. And they found that roughly 20% of all chaplain patient contacts had resulted from a referral. And indeed, most of these referrals come from nurses. Now, for some reason, oh, there we go. Okay, so nurses do make the most referrals. Different studies documenting this, but showing this huge discrepancy in how often these occur. So with one study being as low as 15% of ICU nurses making a referral. This was again a retrospective chart review of several hundred ICU patients. But then, another one suggesting that 82% of nurses making a referral. The Duke study, ICU study, showed that nearly 90% of ICU nurses did make a referral when the patient was actively dying or had just died, or if they raised a religious topic. So, what reasons prompt a nurse to make a referral? Oftentimes it's emotional issues as well as spiritual issues, but the emotional issues in several studies, seeming to be the more common reason. Okay, so I'd like to just share with you a little of the evidence about how nurses make referrals and what's behind that process. So as you saw already, there's this wide variation in the frequency. That may be due to the fact that the samples are as diverse as New York City nurses versus Bible Belt nurses. Who knows? There's also a variation in how this gets measured. Then there are a couple studies that look at document how nurse religiosity is linked with the frequency of a referral. No surprise, the more religious the nurse, the more likely they are to make that referral to a chaplain. But also it's the positive regard the nurse has, the respect the nurse has for the chaplain that, no surprise, is linked with frequency as well directly. Many reasons for referrals are documented, as I've already alluded to, emotional needs. So consistently through these studies, usually it's more emotional needs that drive the referral rather than spiritual and religious, which really surprised me. Often it's when the patient is dying. And in fact, I think one of the myths that maybe need to be busted by nurses and chaplains is to educate nurses that you don't call the chaplain just when the patient is dying. Nurses often do not appreciate or use the skills chaplains have, and oftentimes they're too busy, or they think, they make the referral when they feel like they're too busy to do the spiritual care, or when the religion of the patient is too different from their own and they're uncomfortable with it. Okay, so I mentioned how I had done this study of APC chaplains, and one of the questions I asked them was what reasons most often prompted nurses to make referrals to them. And again, you see the most common one was emotional support related to the patient dying, 95% saying that's what it was. Other emotional support being very high, and religious and spiritual rituals being lower. Isn't that, I don't know, I just find that a surprise. All right. And then I also asked the same sample of the patient care encounters you had during this past week, roughly what percentage occurred because of a nurse referral. So this is more, data from only 4 years ago compared to the previous data that's over 25 years, no, more like 20 years old. And you see here roughly, more than half said that those referrals were no more than 40% from a nurse. Okay, now to look at it from the nurse perspective, one of the studies I did is I actually pulled data from 4 different studies, including one that I had done that uses a scale I've developed that measures the frequency of various spiritual care therapeutics. And one of the questions on this questionnaire is, how often have they arranged for a chaplain to visit a patient during the last roughly 2 weeks of work if they worked full time? And you'll see here, basically 40% of these nurses said they never made a referral. Well, so there is room. And then you'll see there's another item about how often they arranged for the patient's clergy or a spiritual mentor to visit. And of course, that's much less common. Okay, I just want to share one study because I think it is really quite interesting, and it comes from Switzerland. But they did this little experiment where they assigned patients into one of three groups. In one group, the nurse approached the patient and asked them, do you want to have a visit of the chaplain of this hospital unit? The third group was given a chaplain visit that was at least 10 minutes. And at the end of that visit, the chaplain inquired if there was, quote, a desire for spiritual support. And then the third arm, of course, was the control group where there was no query at all and no chaplain visit was spontaneously offered by any clinician. So what are the findings? You probably won't be surprised, but when the chaplain asked, 86% of these Swiss patients said, yes, I would like to have a chaplain visit. When the nurse asked, only less than 40%. Less than half of that amount agreed. And then the control group, if no one inquired, not even 4% volunteered or spontaneously asked for a chaplain visit. Very interesting. Okay, so what you're seeing so far here is just a sense that the rapport between the chaplain and the nurse, and especially maybe between the nurse and the chaplain, is really key to whether or not these referrals get made and the collaboration happens. So given that, what's the evidence about that? Well, first of all, let's just take a temperature on what you all think. So Andy, if we could bring up that poll again, which is closest to your view about nurses and spiritual care? Is it that nurses just shouldn't be part of spiritual care? Is it that they should be limited to just screening and then making a referral if there's distress? Is it that nurses should be completely independent and free to provide spiritual care, consulting the chaplain when expertise is needed, as perceived by the nurse? Or, except for screening, spiritual care should only involve a chaplain, sorry. So yeah, which of those in your heart do you think is the best answer? Just take 10, 15 seconds here. All right, Andy, shall we pull up the results? All righty. Okay, we've got a little more distribution here. So we've got the majority here saying that nurses should be independent but use chaplains if needed. But we've also got quite a few saying maybe we should just have them do the screening, maybe the referrals, and then involve chaplains if more help is needed. All right. Well, thank you. So let's have a look now at what the literature says. So if I was to summarize this literature that informs this, I would say it's that nurses perceive that there is an overlapping role with chaplains, that a lot of spiritual care can be provided by both, but that there are some things that the chaplain can do that a nurse can't do. Also, from my own project with the APC chaplains, I found that chaplains and nurses do have considerable respect for each other, but also hesitations. And this is mirrored in some of the other literature as well. So let me just share with you some of the findings that I got from the APC chaplains. As you see, there are about 300 of them. It was a really nice sample with a lot of diversity, but they're primarily chaplains that work in a hospital setting and are very well qualified as chaplains. Okay, so I created a number. I had to come up with the scale to measure what their attitudes or perceptions were about nurses in terms of spiritual care. And these reflected not only the literature, but these conversations I was having with chaplains as well as nurses. And it ended up, when we threw the data into the hopper, so to speak, 2 subscales came out of it. One that looked at the nurse providing spiritual care as helpful, and then another scale that I'll share next where potential harm could be done by the nurse. So as you see, the scales go from 1 to 4, being very often. And I'm not going to go over all of these, but I just want to point out that roughly between like a 2 and a 3, so between sometimes and often, you have, chaplains saying things like, nurses providing spiritual care that is patient-centered, that is within the scope of their practice, and that they understand chaplains and so forth. So, that's okay. That's okay. Pretty good, right? But the juicy, and I guess maybe I should make a caveat here. There are times where maybe in my presentation it might appear like I'm bashing nurses or I'm bashing chaplains, and please understand that is not my intent. If anything, my intent is maybe to be provocative so as to prompt change. But I just want to maybe name reality and use that as a springboard for bringing us together. So with that caveat, let me share with you what chaplains believed in terms of a nurse's spiritual care is being possibly harmful. Again, the same response options. Let me, and again, the response options roughly between 2 and 2.5. So being close to sometimes. So, not as high as the, I think nurses are helpful responses, but still there's, I'd say something here to look at. So instead of going over the numbers, I actually want to read the items because these were very helpful insights. Most of these were shared with me. Some of you know John Eman, who is a chaplain in Philadelphia. And during a phone call and email conversations we had, he suggested to me some of the cautions he has about nurses providing spiritual care. And they were really eye-opening to me. So I'm going to share these, especially for the nurses in the audience, so that it really helps us to see how chaplains see us and help us to consider the potential for harm we might cause. So it's possible nurses in providing spiritual care may be leading or directing in their interactions. Sometimes they may introduce their own religiosity. Sometimes they misread patient politeness in response to spiritual care as interest in it. Sometimes nurses provide unsolicited religious self-disclosures. And then overall, an item that just said, do you think nurses provide spiritual care that's potentially harmful? So as you see, the average was yes, sometimes. Okay, so what to okay, let me back up here on this one. Spiritual screening. As you know, I think especially back in the late 2000s, like around 2009 or so, the chaplains started making a shift for us in healthcare in terms of what the various roles in the process of spiritual assessment might be. And assessment has been the word that everyone has used up until recently. But now there's thought that the process of spiritual assessment actually begins with a spiritual screening, which is an initial question or a very brief set of maybe 2 or 3 questions that are geared to identify whether there is any active or potential distress that would require more attention. So that's the screening. And some would argue that any clinician should be skilled at doing that. Then the next stage is for perhaps the primary caregiver. It might be the primary nurse, could be a family physician, whatever. But for those who are primarily providing care, then they would be encouraged to take a spiritual history, which is a slightly more in-depth sense of who that patient is as a religious or spiritual person. The FICA tool being one that's commonly used for that. But the spiritual assessment, to use that language now, has been a term saved for that in-depth spiritual assessment. And it's thought that it's the chaplain who is the expert who would be the one appropriate to collect that data. So given that background, when we asked chaplains what they thought in terms of nurses doing spiritual screenings, because in my conversations, I had some chaplains telling me, you know, I do not want nurses to do a screening question about whether they want to see the chaplain or not, because oftentimes a patient will say no, and if they say no, then I don't have a chance. Whereas if I can make a cold turkey call and gain rapport with the patient, then I can maybe, you know, really do some good for them. So with that in the back of my mind, we included a few questions about the nurse and spiritual screening, and I'll just share with you here. One here, the chaplain's perception of the skill level that nurses have at completing a spiritual screening. And so you'll see, you know, way more than half of them saying they didn't think, you know, nurses at best occasionally or sometimes had that skill. So a take home there is, okay, so maybe chaplains can help us nurses and understand what they want us to do in terms of spiritual screening. Okay, and again, feeding on that, you'll see from this screen that more than half of the chaplains wanted nurses only to screen for spiritual distress, and but only 17% saying they never would want the nurse to inquire whether patients want a chaplain visit. Interesting. Okay, so in my conversations over the years, and this included when I worked in New Zealand with chaplains there, I had chaplains tell me stories about how they felt like nurses created resistance and difficulty for them to actually go in and be with a patient. Or the word gatekeeping came up. So I went ahead and put this question in there. Now you can legitimately argue with me and say, well, my question was leading. Yes, I suppose it was. But like I said, I like to be a little provocative and shake things up. So anyway, I did it. And here are the responses from these nearly 300 chaplains. So you can see that basically half of them say, oh no, never or rarely does that happen to me. But you also see close to half of them saying, well, more than half of them saying that at least occasionally it does happen to them. So this documented that what I was just hearing anecdotally really does have a more pervasive experience going on. So it was only natural then to ask in an open question of these chaplains what they thought might contribute to this gatekeeping, that if it happened, if they perceived it, what contributed to that. So these are busy slides, and I'm just going to plow through. I'm not going to read all of them. I'm just going to give you the themes, maybe a couple illustrations. But just know that these slides, I've sent them to Andy. I can send them to you, Pam, as well. Feel free to contact any of us if you want them, and then you can, you know, read it more at your leisure if you like. So here's what these chaplains thought. They thought the reason that gatekeeping existed was because nurses simply didn't understand them, didn't understand their role, didn't understand who they were as religious or non-religious people. Maybe they had had a bad experience with the chaplains that created mistrust. Anyway, it led to patients feeling like the nurse had to protect them from that, from the chaplain. So as one chaplain put it, we need to increase the nurse's comfort so that they don't feel invaded by us. We need to earn their trust. Also, they thought that some nurses had territoriality issues. They wanted to claim spiritual care as their responsibility and not share that for some reason. Yeah. Others had proposed that maybe nurses had fears that affected the professional relationship. And chaplains worried about maybe not being able to build a good relationship and trust with staff. And then delivery system issues, knowing that the chaplains were stretched too thin. Maybe that's why nurses wanted to protect the chaplains and not make so many referrals. Who knows? Or maybe simply the nurses were just too tired to call. But also possibly these issues exist because of personal, spiritual, religious perspectives of the nurse. I know there are some nurses who have given me data that suggest if they think that, this might be a nurse with some, how do I say this, maybe more fundamentalist or rigid religious perspectives and evangelical kinds of perspectives, that would fear that if a chaplain of a religious tradition that was too different from his or hers might not help that patient or might not allow that patient to be saved, or who knows, there could be things like that going on. So yeah, some confusion or baggage regarding the role of spirituality, or what it is, how it manifests, and indeed how a chaplain is trained to address it in very pluralistic ways. All right, so one last question I asked these chaplains in an open question was, okay, so what are the 3 things most that you would want nurses to know about chaplains? So when I thematically coded these data, here's what I came up with. Not only we need nurses to know that we do more than praying. We do more than religious rituals. We do more than just being with people when they're dying. We need them to know that we actually have training, CPE. We're not just pastors from a local church. We need them to know that we can respond to this broad range of religious traditions or even lack thereof, and that we're not there to proselytize. And we need them to know we're there for them as nurses, not just for the patients. We need them to know that we're interdisciplinary team members who can complement their care. And here is one very pointed quote from a chaplain. I don't make medical, nursing, or social work assessments. So I don't want a nurse to do my assessment for me. Wow. All right. So if I mentioned there's no more than 30 or 40 articles in the literature. And when I look at the empirical evidence about the nurse-chaplain collaboration, maybe it's only 20 to 30. And here is my critique of that body of evidence. The methods used are nearly always of very small samples. They're convenient samples, so we really don't know how generalizable these findings are. They're often surveys or qualitative methods. Nothing wrong with qualitative, but we do need to go to the next level. Build on that. After we've identified there's an issue, what do we do next? Measurements often lack validation, always cross-sectional designs, no longitudinal or interventional kinds of research going on. Indeed, there are no studies that test an intervention about how nurse-chaplain collaboration was addressed and whether that did any good. Also, this literature always looks at provider perspectives and never asks patients what they think about this team spiritual care that's given. So all this to say, I would argue that the evidence is scanty and or weak. And I invite you to join me in addressing this topic further. All right, so now in the last few minutes, I would like to just think about how we can collaborate together more effectively. So let's start it off with another question. So Andy, if you'd bring up that poll again, how do you most often collaborate with nurses? If you're a nurse, how do you collaborate with chaplains? If you're a chaplain, how do you collaborate with nurses? So would you say, well, most of the time I really don't, or there's, my work doesn't allow it? Or is it primarily by making or receiving a referral? Or is it primarily that you really roll up your sleeves and talk to each other and discuss and or plan spiritual care for specific patients or family members or clients? Just take a few seconds there.
good idea. He said he wanted to talk to himself. So next time I'm there, I'll call.
All right. Do you think we have responses? We can just go ahead and close out that poll, Andy. Let's see what they said. Wow. To be honest with you, I was expecting like maybe 90% to say it's just making or receiving a referral. But we've got 44% of you saying you actually discuss or plan spiritual care together for specific patients. Wow. So things are going well there. Thank you. All right. So like I said, I'm just going to sit in my armchair, so to speak, here at home and offer some of it informed by evidence, but offer my thoughts about where we can go forward. So question comes up, in order to enhance the referral process and make sure the referrals are appropriate and that the patients who need the referrals are getting referred and so forth, should there be some sort of standardized screening protocol? Do nurses need to be educated by chaplains for that? I'm leaving that as a question. Then there are issues about documentation and maybe if a screening and documentation can somehow be integrated in the health record. You know, I know every institution has its own system for this. There are a few articles that discuss how organizations have developed documentation for spiritual care. But I also know the reality is there's evidence that shows nurses may do all this documenting because they're taught if it's not documented, it wasn't done. However, nurses rarely read their notes, and I don't know how often they would read chaplaincy notes. So I think systems maybe have to look at this, you know, organization by organization to see what would work for them. Okay, but I do think there's often room for educating the nursing staff about when and how to do this referral and whether to ask a patient first. Those kinds of things need to be ironed out. And along with that, you know, just understanding what are manifestations or symptoms of spiritual distress. Not every nurse necessarily knows what that looks like, or even when they witness it, they may not, it may be something they just run away from and don't realize they can do something about. All right. Just an example, this is from 2009, an example of a proposal, a protocol for how chaplains and other clinicians can work together in this process of assessing and providing care. So just know this is one, there are a couple others I'm aware of. So this is a slide for nurses, and it might be helpful for chaplains when they go to educate nurses. But the question, you know, this idea about nurses potentially inflicting harm on a patient because they may open Pandora's box of spiritual distress in a way that they cannot address, or perhaps they address in a harmful way. So having chaplains being able to educate nurses about this, I think is really important. And David Hodge is actually a social worker, and many years ago he gave these criteria I think are very helpful in terms of whether after a spiritual screening one should go and assess more in depth. And he argued that the reasons for going further beyond a screening would be, well, is the spirituality or religiosity actually important and relevant to this patient? Does it respect patient autonomy? In other words, does the patient want this and give at least some implicit consent? Is the patient competent to do this? And ultimately, is it even relevant to health and healthcare? Oftentimes, well, I don't know about this. Maybe oftentimes nurses raise spiritual or religious topics with the patient simply out of their own curiosity, or perhaps for ultimately reasons that are proselytizing. So I think it really needs to be drilled in for all of us that this is an area that is important to address, but it's important to address it when it's relevant to health, or as it's relevant to health as well. Okay, so if your referral rates are down and you want to increase them, here are a couple sources who made recommendations. These are from nurses on what they thought chaplains should do to meet the spiritual needs of the nurses. So if chaplains are, if nurses are experiencing the chaplain as comforting, as inspiring, as whatever it is, then it's going to increase the likelihood they'll say, well, Chaplain David did that for me, so I want them to do it for my patients. To build chaplain-nurse relationships, in this one qualitative study by Kim et al., they talked about how they experienced chaplains as coming and going and being too busy and not really having a consistent presence on a unit. Yeah, and then I think nurses just need to be educated, perhaps in staff orientations or elsewhere, about what the role of the chaplain is and what their skills are, what they can do. And then, of course, about that referral process. Okay, so just ideas about how, where this education could happen. Staff orientations, newsletters, bulletin boards, email blasts, in-services, and so forth. Strategies, thoughts that come to my mind. We've given nurses are super busy. Really important to just put these into little, package the education into very small bits, be very concise. And also nurses, I hate to admit this, myself included, we tend to be very concrete. So come to, and yet chaplains, I think, often come from a more philosophical and theological background. So their orientation may be more of a thinking kind of person rather than a feeling and doing kind of person. So try to cross that bridge perhaps. Use illustrations, invite shadowing, seek new staff out for personal connection with them. Identify nurse champions and train the trainer sessions might be helpful. You might have on each unit your spiritual care nurse champion. Use usual care, especially usual care that maybe didn't go right, as opportunities to educate. And you, of course, can always share articles from the literature. So bottom line, when I collected these data from the chaplains, what it underscored for me is simply the need for us to talk to each other, to communicate. And of course, communication is not just talking, but perhaps there are other forms like documentation. So before and after patient visits, I found it interesting. In my own experience at the bedside, it was a brief experience, only a couple of years in an oncology unit. But to be honest with you, we had a strong chaplaincy department at my community hospital, but I don't remember a chaplain ever debriefing on their visit with me. And I know back in those days, I don't think they really documented either. So chaplains were these lovely people we might have a brief friendly conversation in the hall with, but we didn't really appreciate, we didn't understand, we didn't appreciate what they did. We didn't know what they had done, didn't know how to carry their work forward because we didn't talk about what they did. So this one study done by a team of ICU physicians, Choi down at Duke, did this retrospective chart audit, many admissions to the ICU, and they found that 57% of the chaplain visits, they had documented that they had discussed that visit with the RN. That actually really surprised me. I would just guess that may not reflect a national norm, but maybe I'm wrong. This study also, or another study by this team, documented how many ICU nurses said they would be very receptive to regular rounding with a chaplain. I've already talked about documentation a bit, but I'll share a little more in a second. Then, of course, the obvious, especially for those in palliative care, we're used to chaplains being part of a team conference. But I'd like to share with you, there was one study here, Wittenberg-Liles, who did actually recordings, audio-visual recordings of team conferences in a palliative care context. These were family conferences. And one of the things they did was measure the frequency of how often the members of each team, the disciplines represented, how often they contributed to the conference. And the chaplains, when looking at all the contributions, speech was less than 4% by chaplains. So I know my personal experience of watching team conferences, I've observed, I guess, the same. I don't know about 4%, but I think oftentimes the chaplain may be the quietest person at the table. So it might be important to think about, well, why is that? And, is that good, or is that something we want to change, or change partially? There's something to reflect on. All right, so I mentioned documentation. I share this, but I'm afraid it may be quite provocative. And keep in mind, this was a chart review done by a team of physicians, ICU physicians, and their perception of the narrative documentation that chaplains made in the medical record was that chaplains used code language. So like these doctors didn't know what the chaplains were talking about a lot of the times. Often they felt like what the chaplains wrote narratively could have just been accomplished by ticking some boxes that were located in the EHR elsewhere. They also perceived that chaplains often just made observations but didn't give interpretations, which I think is maybe in a sense, reflective of the paradigm of spiritual care. But nevertheless, it's just good for us to give that a thought. Follow-up plans to them appeared passive, and their assessment was that sometimes insights about relationships were given, so a positive. Okay, and in terms of crossing the bridge and communicating, talking with nurses, just appreciate that nurses might tune into certain language and terminology. Know that nurses buy into this idea of evidence-based practice. So when you say the research documents XYZ about spiritual care, they may listen more. Also, when you distinguish between spirituality and religion, many nurses will need to know that's your framework, the chaplain's framework, and because that's very important to nurses. Also know that nurses have these taxonomies for their nursing diagnoses, and within those taxonomies are spiritual and religious language. So we actually have language for diagnosis of spiritual distress and impaired religiosity and that kind of thing. We also have language for the interventions and the outcomes that are related to spiritual care, spiritual health outcomes. So just know those exist, and you could, maybe with your nurse champion, find out what that language is and use it in your education or just in your face-to-face conversations. And then lastly, always good to get support from your nurse leaders. And here are some of those. The last one there about developing an advisory council. A technique I learned in New Zealand, because I think it kind of comes out of the UK a lot, but the idea of getting your key stakeholders and meeting with them, let's say quarterly or so, to talk about how spiritual care can be rolled out better might be a really great intervention for you. And then even doing QI. I know chaplains are increasingly taught how to do research and quality improvement. And just the process of doing that would teach nurses more about you. And indeed, you would learn more about nurses if you were to do some type of QI survey. All right, so a whole bunch there to digest. just take a moment here maybe to reflect. What would be one strategy, maybe one thing that's not new, but you want to have more resolve about and take back to work and implement? Or maybe there was a new idea or something I said that triggered a new idea in you. What would that be? All right, that is my email address. I am more than happy to receive comments or questions or illustrations, input from you on this topic. Thank you so much. Back over to you. If you have any, if there's time for questions.
Hi, Beth. This is Pam. Can you hear me?
Yes, I can.
All right. So Rabbi Sarah Baruch is going to ask maybe just a couple of questions. We've had a lot of questions coming in. And then everyone, we will take a quick break at 11 o'clock, a 5-minute break, and then come back for the panel discussion. And if there is time during the panel Q&A, we'll bring back some of the questions for Beth at that point. Does that sound all right?
Sounds perfect.
Okay, great. Thank you. Oh, it looks like Sarah might be having some trouble with her audio. Just hold on a sec. Let me see if I can help her.
No worries.
Okay, so Sarah's audio for some reason is not working. She's going to be using my computer for a moment.
Okay.
Hi, Beth. Thank you for those provocative statistics. And we have some great questions coming in for us here. And I'm just going to ask a question and then save the rest for the end after our panel.
Great.
So one of them is, do you know of a standardized communication between RNs and chaplains post-patient visits that is considered as useful for the patient and RN and concise?
Ooh, what a great idea. No, I don't. I mean, I don't go visit all the healthcare organizations in the country, and I haven't asked that question. I don't know. Maybe someone else in attendance does have that, and maybe they could write in the QA or chat box, I forget which it is, maybe they could make that contribution. But I would say, what a fabulous idea for a quality improvement project. Yeah, like develop, get a group of stakeholders together, develop such a tool, and then do a pre and post evaluation of rolling it out and implement techniques for making it continuous. I love the idea.
Amazing.
I mean, of course, a lot of people use SBAR, but yeah, maybe there's something more specific to, yeah, reporting off on a patient encounter.
Yeah, amazing. Thank you. And then there's a question about the impact of the pandemic. Do you suppose that there's been a change in nurse collaboration as a result of the pandemic and the need for staff resiliency?
Yeah. So I think, initially when chaplains couldn't physically be present, I think the spiritual care workload, should we say, weighed most heavily on the nurse. And but as we got used to knowing how to deliver this care, and telehealth became we became more savvy about using it. I know chaplains became more savvy about using it. I didn't come across anything in the literature documenting that, but I, would make the assumption, I know there's telechaplaincy. I haven't read the literature more specifically on that. Again, maybe room for some QI there. Yeah, sorry, I don't have evidence to tell you about.
Yeah, I know we really to see how that research develops, as the years pass from the pandemic. And then one final one. I mean, you offered a lot of insight into educating staff and methods for doing that. I'm wondering, did you come across a common working definition from the nursing perspective of what a chaplain does, or who a chaplain is?
Yeah, so I think there are like 2 or 3 qualitative studies with very small samples. One in the New York area, one, I forget where the others were. But yeah, I can't say that there was anything profound in these findings, but that what chaplains do is often what a nurse can do. But, like I said with this one study, when we don't have time to do it, or we're overwhelmed, or we don't have the skills for doing it, or the patient specifically requests a chaplain, then the referral gets made. What is a specific attribution or definition for chaplaincy by nurses? Yeah, I don't have anything profound to say there. I don't know, maybe it's because it just is too organic for me. Yeah, try me on another one.
Well, great. I think I see more questions coming in, and I do have a few more, but I think we're going to take a break now, and I will kind of collate these for after the panel. Thank you so much.
Thank you. Thank you all.
Thank you so much, Beth. Everyone who is on this conference, we're going to take a quick 5-minute break just to give everyone a little bit of a break from the screen. And then we're going to come back with our panel for the panel discussion, and we will follow that with Q&A and hopefully be able to bring back some of these questions that have been pouring into the question box. So thank you so very much, Beth. And we look forward to hearing more from you later on. So everybody, we will take a break until 11:06. And then we will start with the panel. So don't get out, or if you do get out, come back, and we'll continue in a few minutes. Thank you.
Very good. There we go. Whoops. I'm not hearing Pam. Let's see.
No, that's because I put myself on camera and muted myself.
Okay. Oh my goodness. It's wonderful to be able to do this via camera, but at the same time, it's like, oh, the technology.
It's all crazy sometimes, yes. So we'll start in a few minutes with our panel, and we've got a slide up here for those of you who have not taken a break at this point of who our panel members are. We have 6 panel members. And I will be introducing them in just a few minutes. But that was just such a very interesting and provocative presentation. I don't know if I told you we did a assessment of our department services earlier this year, and a lot of what you were bringing up was stuff that we found ourselves, and we're going to be looking into how to educate and collaborate more with our teams. What we found was that they really do want collaboration with us, but as you mentioned, there are a lot of blocks in the road for that.
Yeah.
So,
I think blocks that are easily removed, though, if indeed you've got a trained chaplain. One thing I didn't unpack, because again, I didn't want to be maybe too negative, but the reality that there are so many different levels of training for quote unquote the chaplain. So, you've got your board certified chaplain I would entrust anybody to, but then you've also got the volunteer who's the retired minister who never had any seminary and maybe doesn't even have a college degree, but had 4 weeks of, or shall we say 20 hours of volunteer training or something to be a chaplain. This is, and can potentially bring harm to the patient. So then when a nurse perceives that harm has occurred because of a chaplain, then that gets generalized to even the board certified chaplain. So for me, that's one of the issues. I think, I mean, you don't have, yeah, so I'm not sure how to handle that.
I agree. I think there's often a lot of surprise expressed by the multidisciplinary staff we work with when they find out just how much training goes into becoming a chaplain. Yeah.
Yeah.
Well, I'm going to invite our panelists to take yourself onto camera because we will be starting in a minute. It's Bronwyn. Yeah. And as soon as you guys are up and I have introduced you, I'm going to take myself off camera and ask you questions from off camera. Hi, Christina. Hi, Tina.
Hi, it's Laura. Can you hear me or see me?
Laura, I can hear you. I can't see you. Have you found the little camera icon to switch your webcam on?
Me.
There you go. You're arriving.
Okay, good.
I think we are waiting for one more person. Jamie? I think we're waiting for Jamie.
Jamie.
Jamie there?
Laura, you're still not visible on camera. It's just a black box.
Oh, there's Jamie.
Okay.
Hi.
Hi, Jamie.
Hi.
Hi, Jamie.
Hi.
I'm wondering if my video's not connected correctly. I don't know why it wouldn't work. Hold on one second. Sorry, guys.
Okay. Laura, while you figure out your camera there, I will start the introduction, so it'll give you a little bit of time, hopefully, to get sorted out. All right, so our panel, we looked for 3 of our chaplains who had collaborated with a nurse who they thought would be a really great collaborator on this project. And so we're very fortunate to have 3 chaplains with nurse colleagues who are going to be talking about collaboration. And so we have Chaplain Bronwyn Jones, who's worked at Cedars-Sinai, the Cancer Center, since 2014. She's embedded with the Patient and Family Support Program, which is a multidisciplinary team of social workers, dietitians, psychiatrists, palliative care physicians, psychologists, cancer rehab physicians, and nurses. And Bronwyn is a non-theistic humanist chaplain. Bronwyn's collaborator is Jamie Green, who has worked at Cedars-Sinai Cancer Center for 2 years and is the practice nurse for 2 oncologists, Dr. Elaine Meter and Dr. Monica Meter. Prior to working at Cedars-Sinai, Jamie was a home hospice nurse. Then we have Reverend Christina Shu, who is the lead interfaith chaplain and chaplain for the supportive care medicine team at Cedars-Sinai. Christina's collaborator is Laura McVeigh, who has been a registered nurse for 27 years. She's been in palliative care for the past 10 years and now serves as a nurse practitioner on the inpatient supportive care medicine team. Then we have Chaplain Rodney Foster, who recently graduated with his MDiv and became board certified. Rodney has an interest in patient autonomy, equity issues, and justice, with a focus on improving staff, patient, and family interaction. The goal of Rodney's doctoral project was to develop a praxis to improve interdisciplinary communication between the medical and support staff and patients and family members to result in improved patient and family healthcare. Rodney, interestingly, has also worked in broadcast news for over 40 years as an assignment editor and producer, and has garnered local television Emmys and other recognitions. He's also currently working as a hospice chaplain based here at Cedars-Sinai Medical Center. And Rodney's collaborator is Tina Tran, who has worked on the oncology and hospice unit since she started here at Cedars-Sinai as a new grad in 2017. And Tina expresses that the chaplain department is a great resource to patients, especially when adjusting to new diagnoses or end-of-life conversations. And she's very happy that chaplains are part of the team. So thank you so much. I think we have a team of ringers here, people who really do appreciate spiritual care and collaborate really well. But I think we have so much we can learn from that. So I'm going to jump in with our first question for the team, and then I will get off camera over here. So our first question is, I'm wondering if you could describe a time, each of the chaplain nurse pairs, if you could describe a time you collaborated on a case, how it worked, and maybe what did not work. So maybe we'll start with Bronwyn and Jamie.
Okay. So I think I'll get going on the background and then ask Jamie to jump in. This particular patient that we shared, it was sort of had a build up crescendo because towards the end we really worked very closely together. I had known this patient since 2018 and seeing Jamie's only been here for a couple of years, so you must have got to know her later. But the main thing I want to share about this patient is she was super private. And independent, and she didn't like sympathy, and she didn't like any sense of pity. So very early on, she said to me, "Don't give me that chaplain look." So I kind of got rid of that immediately. And she defended herself very much with humor, and she was very funny, and everyone really fell in love with her, but knew that they really had to be careful how mushy you got with her. And she referred to herself as the cancer center reprobate. Now, key to this is her mother was a Holocaust survivor, which she occasionally shared, but not all the time. Her deepest fundamental spiritual distress was from knowing that her cancer was causing her mother even more pain in her life, and she was in her 90s, and they would talk every day on the phone, and there were times where she would pull it together to fake it on the phone so that her mum didn't know how sick she was. So, but after many months of spiritual care visits, she began to trust me, and in an email she once wrote to me, "You are the silver lining in my chemo cloud." So she wouldn't let anyone outside of the cancer center help her, so none of her friends and family. We assumed she had nobody. It turns out that's not true. When she went into hospice, she was surrounded by friends and family. So what happened was Jamie and I were very involved with, we found ourselves providing a bridge from a decompensating outpatient person, right? She was in a wheelchair, she could barely walk, she could barely keep awake. She's really actively starting to die. And then we had to transition her inpatient in a way, like trying to gently move her along into accepting hospice, right? Would that sound about right, Jamie? And how did it work your end for you? Yeah, how did we work together? I think you jumped in with an email first off, right?
Yeah, so with this particular patient, it was very difficult to get to know her, for her any help. She refused a lot of services that we offered to her. And so I think what was so crucial for her was that Bronwyn had known her for a long time and had kind of almost like cracked her facade a little bit to be able to get in there. And then that allowed me to get in to help her with the nursing side of things, because she wouldn't let me help her with anything for a long time, nursing related, symptom management. I mean, she was just like, "I got it, I'm going to handle it on my own." And so it was the communication between Bronwyn and I think we were communicating almost daily for a little bit, either email or in person. You know, okay, I spoke to her on the phone. Okay, you know, I went and saw her, you know, back and forth. And we really needed each other to be able to provide like a full spectrum care for her, because I couldn't have done that with her if Bronwyn hadn't kind of made a crack for me to get in there with her, to be able to support her and get her inpatient, and then we get her set up with hospice as well. So it was a very much needed relationship for this particular patient.
Yeah, it was a total blow by blow, like everything, because it was tweaking. When can we bring up hospice? Like, when is the right time to put it in? So that's why it worked really. We worked really closely together on that, and it worked. Yeah, so that's the basic story.
Thanks so much, Bronwyn and Jamie. And I love how that you supported each other in supporting the patient.
Oh yeah, yeah. We really liked her. We miss her still. Yeah.
Thanks. Let's hear from Rodney and Tina.
So for us, I know Rodney from him being an intern on our floor. So it was really helpful for us to know each other before we started working together. I knew he was staying with this patient and their family and visiting them often, but the extent of what he was doing for them until it was time for him to discharge. And so for this young family and like this new diagnosis, it was really hard for them to leave the hospital setting where they were cared for and supported by like experts and go home and have that fear of just being on their own. And it was that time where he was on the gurney and getting wheeled off to go home, and Rodney came over, and you could see his face have like a sigh of relief, and to see that all of his practitioners and care partners sent him off, gave him a lot of support. And it was in that instance that I realized that it was a very like collaborative team effort to get him to accept his diagnosis and feel comfortable about leaving the hospital.
Can you guys hear me?
Yeah.
My mic was dead. Okay. Thank you, Tina. Yeah, this was a pretty young family, if I remember correctly. The guy was maybe 45, 50 years old and married, and he had a couple of teenage kids. And he was having a hard time. He had a lot of a long period of pain and suffering. And as far as how Tina and I collaborated, you know, what was beautiful about it, first of all, I have a lot of respect for nurses anyway, because I think you have to have a certain heart to do this type of work. And that's what, and they have to be intuitive and they have to be caring. So I already knew that. And then Tina and I would occupy the room space together sometimes. And so we would cross over. We were respectful of each other's professional space, even though we were in the same physical space. And so I could tell as I watched her, I'm not a nurse, so I don't know exactly what she was doing, but I could see the response of the family and how they felt comforted, and they felt taken care of. And I could see there was an ease because it was mostly the guy and his wife, because the kids just couldn't take it. I could see a sense of ease when Tina was in the room. And when we occupied the space together, it was like, hey, Tina, should I leave? And she's like, no, you stay. Or if I was, we were respectful of occupying that same space, for giving ourselves that professional space. So, I'm not a big sports guy, but, I see our collaboration, kind of like playing basketball or soccer or whatever. It's like we're giving each other the ball. And, and it's good for us to have some understanding of for me to have an understanding of what a nurse does, for her to have an understanding of what a chaplain does. But basically, we have the same goal. Our goal is to do the best we can, give the best care, the best, emotional, because, when I watch Tina and any other nurses, they're also concerned with the emotional healing and support that's needed for the patients and their family members. So we're both, that ball is what's best for the patient and for the family. And, we would just kind of pass it off and then kind of sit back and, watch the other person and appreciate their work. So our collaboration was, because I noticed in the presentation, a lot of where the conflict came between nurses and chaplains, it had to do with, to me, I sense the disrespect, like, well, nurses shouldn't do this, or nurses were saying a chaplain shouldn't do that. And, my experience with nurses is they're very intuitive. I mean, of course, I've done a lot of training here. My teachers are actually here. And I've done a lot of training here to learn, spiritual care. But on the same token, I wouldn't just distrust. I've never had a nurse, just blow it or not have a good instinct on, how to approach or how to help support a patient. I've just never seen that. They may not, know exactly the specifics of spiritual care, but we're so in line. It just works.
Thanks so much, Rod and Tina. I love that image of teamwork, passing the ball to each other in the best interests of the patient's overall care. Thank you. So let's also hear Christina and Laura about your collaboration.
What a wonderful intro, Rodney. Thank you for all the kind words on the nursing part, but we think just as much about your expertise as well as chaplains. And I think Christina and I are in a different spot. We share an office on the inpatient palliative care team. And so we're constantly collaborating. So we're kind of blessed that way. The patient that came to mind for us when we were asked to do this talk was, it was a female patient that we took care of a few years ago, who we knew very well over a year's time, a little bit more. She was in her 50s. She was diagnosed many years prior with pretty advanced ovarian cancer. And so we were essentially consulted for symptom management. And so I think I met her first, maybe, for symptom management. And when you met her, she took up the whole room. She was just the most dynamic, beautiful person and fun and just really cool. And so she drew you in and you wanted to spend time with her and you wanted to make her quality of life the best that it could be. Obviously, in our team dynamic, we're a multidisciplinary team, so Christina got involved and social work got involved, and it was just a beautiful collaboration for this patient that ultimately passed away a little over a year after we met. And we saw her very frequently. It was fun to look back in her chart a little bit. We had seen her, not counting Christina's visits, we had seen her 94 times, in addition to all the visits that Christina did. So we're very lucky to have cared for her.
And I'll pick up on what Laura shared about our patient. I think I like the image of a basketball team, because I think for this patient, it often felt like we were just handing the ball to one another as the palliative care team took care of her. We communicated constantly about whether or not we wanted to see her together. So like Laura and I would visit together, or maybe we would say we're going to go separate. And I think that really allowed the patient to speak to different aspects of her illness. I think one thing that really caused her a lot of distress was pain in her legs, which meant that she was losing independence and losing her role. She was a gardener and a chef and caterer, and so to be active and to be able to be in the garden and to be on her feet and making food for other people was really important. And so whether it was talking about symptom control, it was also related to like those feelings of loss and those feelings of her hope for getting back to her business, which she ran with her family. So it was also about family relationships. And I think as our patient's illness progressed and we started to bring up conversations about hospice, and our patient even brought up physician aid in dying at one point, Laura and I were able to support one another in both brainstorming like the best strategies or the best ways to communicate and to allow our patient space to talk about her feelings, to debrief about our own sadness and grief about just, you know, that such a cool and amazing person was coming to the end of her life. And even to debrief about challenging times, because our patient was also, I think, really prized control. And sometimes she would just tell us, I don't want to talk about sad things, or I don't want to go that deep. And we could kind of read her signs and tell. So we would commiserate about how frustrating that could be sometimes. But ultimately, I think Laura and I just really remembered her as a time where I think it felt like our whole team was really caring for her in a unified way. And there was such a, I think, a collaborative blurring between the lines of like what a chaplain or a nurse practitioner or a social worker did, because we all really wanted to provide a holistic type of care for her and her family. That's our case.
Thank you, Christina and Laura. What I'm really hearing from all of you in talking about this collaboration is not only how this was in the best interests of the patient, but also how it supported you by being able to collaborate with someone else in the care of, in the interests of the care of this patient. So clearly you're all really good at collaborating with each other, but I'm wondering, the next question I would like to ask to the three nurses on the panel, what barriers to collaboration do you experience? Have you experienced barriers to collaboration with the chaplain? Or if you yourself don't, have you experienced barriers to communication with the chaplain and collaboration with the chaplain among your colleagues? What might some of those barriers be?
I think a lot of it has to do with knowing your resources, and a lot of the nurses, at least on the inpatient side, are more focused on, you know, being a nurse first, because that's their like new role. It's hard for them to see beyond their tasks and see what the patient needs spiritually. So maybe there needs to be some more, you know, training with the newer nurses to see what resources they have, especially also with night nurses. They don't see the presence of the chaplains always on the unit at their time of day.
That is a great point, Tina. Jamie?
Yeah, for me, I was going to say, I think my hesitation is often that I don't want to step on any toes. And so I don't want to assume someone's religion or that someone needs, you know, spiritual chaplaincy or something. And I think that's a me thing, or, you know, maybe multiple nurses have this, but I think that's not something that needs to be there, I guess is what I'm trying to say. Like, even this presentation, I'm like already thinking in my head, wow, there's so many people who would benefit from speaking with Bronwyn more that I'm not, you know, capitalizing on right now. So I think training would be great. Like Tina said, I think also just, you know, like reminders of like what our resources are, and, you know, it doesn't have to necessarily just be like the people who are bringing religion up to you that you know, that you offer a chaplaincy referral to. It can be anyone.
That's an excellent point. Thank you. Laura, did you want to add anything?
Not really. I mean, Christina and I talked about this, and I don't find any barriers really in my role right now on the palliative care team, obviously with Christina, but other members of the chaplaincy team. I think as a newer nurse, me personally, I would hold back on reaching out to, you know, chaplain services just from my own ignorance. I didn't know enough about maybe a certain religion. I didn't know what they needed. And so just learning over the years, especially, you know, while in palliative care, you just learn, you know, who your resources are, like Tina and Jamie are saying, and educating yourself and others on the, you know, the beautiful collaboration that you can do with chaplains.
Thank you so much. I want to turn the same question to the chaplains. Have you had any barriers to communication and collaboration come up in your experience, or among other chaplains that you work with and have seen?
Well, I wanted to jump in because I thought about this, and then Beth's presentation sort of covered all of it, most of it. It's like I'd written down several things that had already been brought up in the very thorough presentation that I thought brought up a lot of the issues. But I think for me, I often don't get a referral to an infusion center nurse actually sees me walk by and then they grab me by the collar. So it's partly just they forget that I can be used. And the other is, and this is really good because I'll be able to take this back immediately. We have a lot of new staff right now. Since COVID, there was kind of a leaving and a lot of travelers, and now we have hired a lot of new staff. So I'm going to work out with the nurse manager as me being part of the onboarding process of new nurses in the cancer center. So even if it's just like, tell me what their name is, I'll find them and I'll go introduce myself. But I think that is really important because I realize I'm leaning back on my old relationships and I need to start forging the new ones. So I got a lot out of that. Thank you.
Yeah, excellent point. Christina, were you going to add something?
Yeah, I was going to add, when Laura and I were brainstorming, we were thinking about the role of joint visits, which in palliative care is often part of the norm. But before we joined a palliative care team, I don't think we'd ever shadowed or had a joint visit with one another's discipline. And I think that that is amazing. And if there's an opportunity during training or during education to provide that, I think it gives so much insight into what other disciplines do and what their day-to-day is like and what the challenges can be and how we can help one another in bringing different expertise, like whether it's like seeing nursing and how many times they're called into a room and how they're juggling like different tasks for patients, or a patient who is maybe refusing to take their medication because they want it at certain times, and a chaplain can kind of listen and elicit that information and help collaborate with the nurse so that there's a better balance for the patient to take their medication, things like that, where we're really helping to make one another's day smoother. I think that, yeah, there's a great role for joint visits and shadowing. I'll also share just an anecdote from a nurse, not Laura, but another amazing nurse at Cedars who frequently calls spiritual care. And I had gone in to see a patient and they declined any chaplain services. And I came out and he was like, oh, that was very short. And I was like, oh, well, you know, they said they didn't need anything. And he was very kind and just said, it's really great that you just came and showed up. And I feel much better knowing that we offered additional support to this patient. And it really made me feel like there was this value that I was giving, even though it wasn't directly to the patient, but it was for the nursing staff.
Wow, yeah. Thanks, Christina. Rod?
Okay, you know, you guys know from CP, I've told this story before, but you know, one of my first patients I went to see, I came in the room and I said, hey, you interested in spiritual care? And she's like, oh, no. I said, well, can I come back tomorrow? And she said, no, come back in 20 years. So the thing is, one of the biggest barriers is there's a lack of understanding about what we do. And the only way to and that's one of the first things you guys taught me, you know, and that's a big experience. And that's what I've heard the nurses on our panel, and I've also heard several times, is that they're not sure what to do because they're not completely clear on what it is that we do. You know, Tina's on the panel, and Tina and I we don't talk a whole lot about the patients, but we respect each other's space. But I've got relationships with other nurses. There's a nurse in the infusion unit, and she would introduce me to patients, you know, and I have the nurse that I work with in accent care, and every day we just do a rundown. Here's this patient, here's the family, you know. So there's different ways of communicating, but, you know, many of you guys know from my project, my main point in my doctoral project was to improve communication, interdisciplinary communication, because we just need to all talk. Doctors, nurses, social workers, we just need to talk and communicate with each other. And it's good if we have an agenda. So you know, many of you were critical. It was kind of long, but the whole point in this interdisciplinary document was to encourage us all to kind of come together in one thought as a team and to understand, like, okay, as I do a spiritual assessment, but what's going to help a nurse? Or when I do a spiritual assessment, what does somebody tell me that maybe will help a doctor? Or, you know, what would help a social worker, and vice versa. And all that improves by the more that we communicate with each other. You know, one of the first times Tina and I talked, she sat down and told me she was hungry. And we started talking about hamburgers or something, you know. But, you know, the point is, you know, we started communicating, and through watching each other and communicating, we learned how each other operate and how we can best operate with each other. And it's different, you know, with different people, but it's all a matter of us trying to communicate and understand each other's roles as best as possible. So if we're passing the ball, if we're working together, whatever it is, but I think that's the biggest barrier is not understanding what each of us do and being able to communicate in that language, to be able to communicate to a nurse in a nurse's language, or to communicate in their language and their culture, because each of these positions, there's a language and a culture. And the more we talk with each other, the more we learn each other's language and culture, and then we can help each other and have our final goal, which is to do the best we can for our patients and their families.
Yeah, right. Thank you. And that was, I think, what Beth brought up as well, the essential piece of communicating with each other and getting to know each other. There was one thing that I didn't hear from any of you as chaplains, and this will be my last question, because I did have other questions, which, by the way, you've all answered as you've been going through this. But I've heard from a lot of chaplains, particularly newer chaplains, that they feel very intimidated sometimes by the nurses. You know, just really scared to talk to the nurses and find, you know, kind of feel like they're interfering or bothering the nurses. And I'm wondering what you as chaplains and nurses, who obviously collaborate really well together, what would you tell chaplains and maybe nurses about that?
Well, am I muted? When I first started, it was a matter, again, of you know, nurses are really busy, but I've never felt any kind of disrespect from a nurse. But I think it was, at least for me personally, it was my just being a little shy and not completely understanding, because the more I talk to nurses, they're interested in what you have to say, and they're interested in us working and collaborating together. And it was my misunderstanding in the beginning that maybe I'm interfering, or maybe I'm causing, you know, whatever, I'm disrupting or disturbing them. And it turned out the more spoke with nurses, that was not the case. So part of that, I think, is just a matter of growth. At least it was for me.
I think also that what really helps with that sort of thing is a perspective of seeing the nurse as a foundation of information. So it takes off your self-consciousness to see the nurse as a font of information about this patient. So you stop thinking about yourself, you're thinking, so tell me more about this patient. What can you tell me that will help me when I visit them? And then you'll feel more relaxed. That's what I would tell new people.
I also think, I guess I would say as advice to new chaplains to, to do those things like Tea for the Soul, or the things where you just go and hang out with nurses, because nurses are so cool and so funny. And the more that we get to spend time, we see, the things that are challenging, the things that are really meaningful about one another's work, and we have so much in common. So I think that initial intimidation can be easily broken down by like sharing some jokes in the break room.
Yeah.
And one other thing too that was very helpful was the chart at the nurses station.
Yes.
Yes.
To be present, they see you there. Yeah.
Yeah, thank you. That's great. So it sounds like just taking the time to get to know each other as human beings, rather than as roles that we may not fully understand.
Yeah, classic icebreaker is the nurse swears in front of a chaplain, and then it's all over. Okay, we got that out of the way. All right, it's okay.
Are you recommending that, Bronwyn? Okay, I am going to, in the interest of time, I'm going to bring this particular part of the panel discussion to a close. We're going to move to Q&A. And then at 11:50, well, Pacific time, 11:50, so wherever people are in the country, we will have Dr. Taylor do a closing at that point. So we will have a few minutes of Q&A, and Sarah is going to see if her if her microphone is working. So we've had a lot of great questions coming in.
Yeah, I'll second that. So many great questions. I'm hoping you can hear me now. Maybe give a nod if you can. Great. So I'm going to pick up I had a question come in specifically in response to one of our panelist questions. So I think that's a great place to start. Building off of Jamie's comments, sometimes it's personal internalization of the nurse. How can chaplains and nursing administrators help the nurses to address the presuppositions about chaplains? And Jamie, I don't know if you want to answer that, or we can open that up to the panel as well.
I think that, as we kind of talked about, just more training from the very beginning about what it is and more information about what a chaplain can do for you would be helpful. I also think that reminders are helpful. So it's like not just the new nurses that don't know what a chaplain does, it's often the older nurses that, have been here a while and just, things don't stick in your head as much. So yeah, I would say like not only more information from from the start about a chaplain's role for, within nursing training as you get onboarded, but also maybe yearly reminders as well.
Yeah, and that certainly seems like a theme throughout today's conference of just the education at the beginning. And I like that piece about the reminders too. And this question is for the nurses on the team. Can you comment on how much of any training specifically in spiritual care that you received in your clinical training, if any?
That's a really great question. I personally have not received any training. My training has come from the numerous spiritual care people that I've come across in my career. I worked in oncology, then ICU, and then as a nurse practitioner, and then finally in palliative care. And so I've just been so fortunate to have met so many different people along the way, but no formal training, unfortunately.
Same with Laura. There's at least for like the new grad program at Cedars, when I started as a new nurse, we didn't really focus on spiritual care at all. It was just really the encounters that I had on my floor specifically, which is unique because We do have chaplains that come often. Like I know Christina since I started when she was doing rounds with us, like during progressive care rounds, and just seeing how the chaplains work with our patients through their multiple stages of their disease process. And that's really the only formal training that you have.
Yeah, so it's really highlighting that relational piece. Yeah. Another question, one of the roles of the chaplain is to be an advocate for patients and families. And I'm wondering from either Laura, Jamie, or Tina, how is it for you when a chaplain comes and advocates, maybe brings up conflict that's happening between the patient and the treatment team, or maybe even some concerns that were shared with the chaplain about your care, although I'm sure that never happens with you guys, but yeah, how do you guys receive chaplain advocacy? I think that question, I don't know for sure, but might be coming from, I know for myself as a chaplain, sometimes I felt, how do I be a team player with my treatment team, the clinical team, interdisciplinary team, and also be an advocate for the patient and do both?
I don't know that that's...
Oh, go ahead, Jamie. Go ahead.
I don't know that that's ever specifically happened between me and Bronwyn. Whenever Bronwyn brings something to me, I mean, because we have that relational piece, that is information that I take very much to heart. I don't know that there's ever been like a patient where it was like they're disagreeing with the treatment plan or, needing an advocacy necessarily. Though I would speak to the fact that because our relationship is so solid, I would think that I would take that information really straight to heart because of the relationship we have.
Great, thank you so much. Yeah,
I actually welcome it. Christina has pulled me aside or talked to me about certain patients and their care team, and maybe expectations aren't being met, or there's a disappointing outcome with a family meeting, or how they've dealt with a certain situation that I'm unaware of, that the patient had never shared with me, but that they had shared with Christina. And I actually have had some experiences with other chaplains that have sought me out and explained that something went terribly wrong with a conversation with a physician or a team. So I welcome it. We don't have access to every moment that these patients and families are experiencing. So I think it's wonderful feedback that we can get from a different discipline.
Great, thank you so much, Jamie and Laura. We have a question here that just recently came in the chat for the nurses. Again, on the panel, you guys are, people really want to pick your brain today. I love this. How can chaplains support the nurses and other staff? What are your spiritual needs? Any examples that come to mind?
I think what Christina said earlier was really important about building relationships between the nurses and the chaplains. I really appreciate when we do the healing of the hands or the teas for the souls. It's just a good time for us to stop and like reflect, or just it's like the first time of the day where we get to sit down and just be silent for a moment, and I really appreciate that. And that really builds our relationships too. I really appreciate when Rod and I just speak at the nurses station and just lament about our days. That's also really helpful and a good outlet for us nurses, and it builds rapport for all of us in our relationships too, so that we can better know each other and then utilize each other to help our patients.
Thanks so much, Tina. And I guess building off of this question, I think there's a strong relational component to all of your work. Somebody dropped a question in the chat about, when you're entering kind of a crisis or emergency situation where the chaplain has not had the opportunity to previously build rapport with the staff. Any suggestions on dealing with gatekeeping in such situations and jumping in and being able to do collaborative care? And that's for the chaplains or nurses on the panel.
I think I need to hear the question again. Sorry. It seemed
Sure.
complicated.
Yeah.
Yeah.
So the question is, when a chaplain is entering into a spiritual care situation where they haven't had the opportunity to previously build rapport with the staff, how might they navigate this, especially around gatekeeping kind of dynamics that might emerge?
I think I would go to what I said before, just go to the nurse and see them as the font of wisdom and information and start there and ask for advice about anything that might be helpful to move forward and quickly. Yeah. I mean, because I don't do much inpatient work, it doesn't come up as much as it used to.
Yeah, thanks, Bronwyn. So really utilizing the nurse as that fountain of resource. Yeah.
A lot of times, oh, go ahead, Rodney.
Oh, I'm sorry. I could say just in my experience, often, you know, if I'm going to a patient's room and the nurse is outside there, they often just offer information. You know, I mean, I can always ask, you know, is that your patient? And I hope I'm answering the question because that was kind of complex, but I'm assuming just as far as how we would communicate, that happens often. And the nurses will tell me, well, this blah, 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 or, you know, there's a family member in there, or they'll explain the dynamic or things that are important, the emotional dynamic, or, you know, the family dynamic, whatever's going on. That's often offered to me without me even having to ask.
Yeah, that's definitely true, especially in our case on our floor where we have a lot of patients that are end of life. If anyone comes up to us and asks about the patient, usually us nurses, we offer information so that you can help the patients inside, or more likely the family members that are dealing with the family that is dying.
That's what I was going to say as well, Tina. A lot of times, especially when I was working in the ICU, it was so wonderful when someone would show up, even if they didn't know anything about the patient or the family, to just be another person to offer, you know, support to the family while the ICU team was doing their work on the patient. So, and also on the oncology floor, I would imagine you guys utilize the spiritual care quite a bit during end of life.
Great. Thank you, guys. To chaplains, how can you support for patients at night or night shift nurses?
Be there. We just don't have, you know, we have one chaplain, right, who's there at night. I think that's kind of it. If there were more of us there. I mean, with what I'm doing now, I'm there like around shift change, you know, 7 or 8. But I think it's just a matter of a presence. I think we, again, as often as we can, if we're occupying that same space, we work together well and easily.
Great, thanks, Rodney. Going back to some of the questions we had for Dr. Taylor, sometimes chaplains are referral driven and have quotas. How do you inspire more rounding? Have you come across anything in your research that might give insight into that?
Oh, I'm sorry. Are you asking me?
That was a question for you. Yeah, sorry.
Oh, whoops. No, nothing in the literature. Really, the only study that I saw that addressed this, you know, rounding was the ICU one at Duke, and it just simply surveyed the nurses as to what their perspective on it was, whether they'd like it or not. So as far as how to implement it, I didn't come across any evidence, or, you know, nothing descriptive. So again, maybe this is something to just, you know, collaborate on, talk to the stakeholders, talk to the nurses, the nurse managers, say, hey, here's an idea. Would it be helpful? How should we do it? How often should we do it? Would you like me to draft some protocol for it or whatever? What do we need to do to make this happen?
Great, thank you so much. And then I think maybe we have time for just one more question, and this is for the panel. From the point of view of nurses and chaplains outside of hospice, are families bridges or bulwarks to spiritual care? What would the panel suggest for being a patient and healing presence for bulwarks as well? Make sense? I'm not familiar with the term bulwark, so maybe somebody can clarify what that is in the chat.
How do you spell that?
B-U-L-W-A-R-K-S.
Oh, bulwarks. Oh, bulwarks. Wow. Okay. So can you tell us the question again now that we know the word?
Sure. So from the point of view of nurses and chaplains outside of hospice, are families bridges or bulwarks to spiritual care? And what would you suggest for being a patient and healing presence for the bulwarks as well?
If I can just interject really quickly, the evidence, actually, there are several surveys looking at the rates of referral for different categories. And I said nurses are the most common, but they're the most common sources of referral amongst healthcare professionals. More frequently than nurses, it's family-driven referrals. So, okay, enough of me.
Yeah, I think that's really helpful statistical information to keep in mind. Yeah. Anybody else want to add to that? Yeah, Christina.
I guess I'm not sure this answers the question completely, because I think that, it just depends on the family and the patient context. I think that there are times when families are really welcoming or the drivers of a request for spiritual care, and also there are times when they might be more protective. I was going to say that I think what can help for both meeting new patients and families as well as all staff is for chaplains to have like a very quick sentence that explains our role. So even when I enter any new room, I think I'm always saying, hi, I'm an interfaith chaplain who's here to support people of all traditions or all spiritual backgrounds, or I'm here to be someone to talk to. Like I always try to insert like a one phrase thing that gives a very general and very open, embracing view of who a chaplain can be for that person. And I would hope that other people, it gives people a little bit of a window so that they can respond versus just saying, hi, I'm the chaplain.
Well, on that note, to keep us on time over here, this is Pam again. I think we have asked Beth to give us some closing thoughts. I wanted to say thank you so very, very much to our fabulous panel, Bronwyn, Christina, Tina, Laura, Rod, and Jamie. Thank you so much for all the preparation you put into this and for the wisdom you've shared with us. This is such an important topic, both for supporting staff in the hospital and also for providing the best patient care we can possibly do. So thank you so much. And Beth, we're going to hand it back over to you. And thanks, Sarah, also for running the Q&A. So Beth, the floor is yours.
Wow. Yeah, I love it. Thank you all. Before I riff for just a couple minutes to close, I'd love to put my comments in on a couple of questions that were addressed. One was about what are nurses trained in what training do they receive in terms of spiritual care? So let me put my professorial hat on. Actually, starting in 2008, coming up until just this past year, the American Association of Colleges of Nursing's Baccalaureate Nursing Essentials document. In other words, the document that listed all the essential content for an undergraduate, a pre-licensure curriculum, included specifically that nursing students should learn spiritual assessment and care. Now, as you just heard, so any nurse who graduated at least after 2008 should have been exposed to something, but the variation in what is delivered is highly variable. I think your religious or faith-based schools are more likely to give you some instruction, but it's highly variable. And indeed, I often have faculty from other schools contact me about how do I do this. So there's a lot of discomfort with teaching it because there's personal discomfort with providing it. So that's the reality. There is actually a lot of literature that documents nurses feel like they are inadequately trained to provide spiritual care, which mirrors what you heard from the panelists today. So that's the reality. There was a question about COVID and how to support nurses now. Pushed a button in me because I've just begun to crunch data for a survey I did here in Southern California, 3 different hospitals of nurses about COVID, its impact on them spiritually, religiously, morally, and how it impacted nurse outcomes. And indeed, although the spiritual and religious struggle wasn't as great as I thought it would be, the analysis showed it substantially contributed to the nurse outcomes of burnout and intent to stay in nursing, as well as job satisfaction. The most interesting finding was that these nurses, and of course the data were collected just this spring, so after the worst of COVID, but there was a moderate, fairly strong amount of post-traumatic growth. So as what I would say, some spiritual transformation, some silver lining was recognized, at least in the nurse samples I collected from. So for chaplains, how to support, enhance the recognition and the development of that post-traumatic growth and address the spiritual, religious, moral struggling that is going on, that's well documented. So loved what the panelists brought to us, and there were a couple points perhaps I'd like to just highlight in closing here. One thing I thought was interesting is they mentioned how it was actually the chaplain that became the entering wedge for nursing care for the first patient that was discussed. So I thought, I realized I have this implicit negative bias, and that, what chaplains contribute is to holistic care by addressing the spiritual. But no, what I was hearing from the panelists is through what they do in terms of supporting the spiritual well-being, they're also supporting physical and emotional and other forms of well-being. They really are helping holistically when they are helping just spiritually. So I also loved what was said about the importance of respecting each other's spiritual space. And I would say that not only metaphorically, as Rodney's, or literally as Rodney, I think, was saying, but also metaphorically. And it reminded me that my athletic daughter has got me watching, it's on Netflix right now, Playbook, and it's interviews with famous athletic coaches. And the interview with Doc Rivers of the LA Clippers talks about what made his team win was when there was a recognition that they were part of a team. Each superstar was not winning because they were a superstar. It was because they were part of the basketball team. So I think a great way for us to end our thoughts here is to remember it's not about me, it's about we. Or as Dan Siegel there at UCLA, I think he's the one that's coined the term, maybe, it's about we. So maybe that's the take-home word. And then I just like to reiterate a quote I found online. It's literally true that you can succeed best and quickest by helping others to succeed. So by acknowledging the strengths we all bring to patient care, we improve not only patient care, but we're improving our own health and well-being and ability to care. That's what I heard, and I think those are great points to end on. And I thank you all for being my teachers.
Thank you so much, Beth. Wow, those are really wonderful and very wise words at the end. And I think that the idea that we're a team, that it takes a village, putting the needs and the well-being of others first, which I think as chaplains is really what we are about, and nurses as well. And so I think if we can fall back on those basic principles, we've already come a long way to bridging the gaps we've been talking about. So thank you very, very much for bringing your wisdom, your time, your expertise to all of us today. I really, really appreciated it. I also want to just say thanks again to the panel, to the Cedars-Sinai team who've helped put this all together. A huge thank you to Andy Andresco, who's been in the background, who's put in hours and helping us put all of this together. Thank you, Andy, you're amazing.
Thank you so much.
Thanks also to George Frichat for all his support and help and for recommending Beth to us. Thank you very much, everyone. And to all the attendees, I hope this has been a meaningful time and a springboard to further conversation, further research, lots more discussions. Thank you, everybody, very much.